Great. Okay. Good afternoon, everyone. Thank you for joining us today, especially on a Sunday afternoon, for a very special webinar on assessment of suicide risk in clinical practice. Mental health has been shrouded in silence for far too long in our country, but not anymore. And the fact that we are all present here to witness Dr. Anjali address this subject is a testament to that change. Our speaker today is Dr. Anjali Nagpal, who is a renowned psychiatrist based out of New Delhi and a prominent figure in in the field of mental health in India. Dr. Anjali is a consultant psychiatrist at Max Healthcare and the founder and chief managing director of Serenity Clinic, Vaishali, New Delhi. Dr. Anjali has completed her MBBS from Gandhi Medical College, Hyderabad. She holds a diploma in psychological medicine and a postgraduate degree in psychiatry from SMCH, India. She has gone on to work as a clinical research associate at the University of Maryland, USA. Dr. Anjali believes in using a holistic approach in handling mental health problems through counseling, yoga, neurogenetic diet, and lifestyle management. Her field of interest includes using QEEG based brain mapping for diagnosis of depression, anxiety, panic attack, bipolar disorder, psychosis, migraine, headache, ADHD, etc. She also specializes in peak performance enhancement using EEG based neurofeedback and repetitive transmagnetic stimulation for drugless psychiatric treatment. Dr. Anjali was conferred with the Global Top 50 Mental Health Leader Award in 2019 and 2020 by ET Now and World Mental Health Congress, respectively. She was also selected for Hero Leadership Award in 2015 and has also gone on to serve as a psychiatrist on several TV shows, including Survivor India and Connected Humtum, reaching a broader audience and enhancing the mental health awareness in our country. Without further ado, I would like to welcome Dr. Anjali Nagpal. Dr. Anjali, thank you for joining us today. We are truly honored to have you here, and the floor is all yours.
Thank you so much, Vidya.
Thank
Good
you.
afternoon, everybody. So it gives me great pleasure to be here and to be talking about, a very important topic today. In fact, 10th October is celebrated as World Mental Health Day globally, and it has been started by WHO for a long time, and every year we have one or the other topic on which we completely focus. So this year the main topic was mental health for all. So why we say that mental health for all is important, we thought that let us focus on areas where mental health and psychiatry can be of great, use. So suicide is one of such areas where life can be saved. All the suicides can be prevented if action is taken at the right time, if there are some signs which are picked up at the right time, and mental health is taken care of. So today we will be unmasking the enigma, regarding the suicide. What are the risk factors and how we can prevent it? So in fact, while I was preparing for this, I actually came across WHO, and I found out a document, there, which was a comprehensive mental health action plan for 2013 and 30, which has been made. And there a lot of emphasis has been given on, preventing mental health, suicides due to any of the factors. It could be due to some people who are suffering from some mental health problems, or it could be just about losing control, or being aggressive at times, not being able to control oneself, and some sort of externalizing sort of symptoms might be there which may cause it. And now, as we go further, first of all, I would like to go on the stats which are there, that what is the sort of how much is the magnitude of this problem globally, how it is. Then we will come to India, how it is, and then further as we go, we will talk about the population, the cohort who are on at risks. This will be the one who are vulnerable. Then as far as evidence based, what all have been found, that who are the ones who are at risk. And then we will come to how to handle uh, such clients who are at risk, how to pick up those signs, which may be very subtle sometimes, even with the experienced physicians, you may be able to, you may overlook it. So looking for those signs, and later as we go further, then how to while I'm talking about suicide, I'll also be talking about violent patients. So they somehow, somewhere they would go hand in hand, and I thought that would be a good opportunity wherein we talk about how to handle a violent patient if they are there. So it can be in both the cases. It could be because of impulse control problems. So we can talk about both of them together. So, as I said, according to the Comprehensive Mental Health Action Plan by WHO, they have said that by 2000, by 2030, they plan to reduce the suicide rate in countries by one third. So this is a major thing that everybody is working on. As you understand, that we have already decriminalized, suicide, but that is not the case all over the world. So now they are, this year that I have seen in the 2023 document that WHO has, they have spoken a lot about decriminalizing them, and being empathetic towards our clients, especially the ones who are actually thinking of contemplating suicide or self harm. So this is one of these, the global stats that we have. This shows that all over, if you see here, that the suicide rate, mostly is around 9. The global suicide rate is 9. All these yellow ones are 9. And if we come to India, in India, it is around from 10 to 14.9. So just under 15. So this is where India is. And if you see that, especially in Africa and in parts of other Asian countries, it may be well above 15. In fact, while I was going in the details, I saw that the suicide rate in low income group is much higher as compared to the higher income group. That is what the global WHO data says. Then moreover, in Africa and Europe, they are found to have more than 15, the suicide rate is more than 15 in Europe and Africa, especially for men. And if you see, while we come to the next slide, if you see that the suicide rate is more for men in all the age groups. If you can see, it is more than, it is more for men as compared to women, or the common sort of suicide rate. And if you can see here that more than 7 lakh people have died by suicide in 2019. This is again a WHO data that I'm talking about. And suicide was found to be the fourth leading cause of death among 15 to 29 years of age, in 2019. And out of which 58% of suicides happen mostly before the age of 50 years. Then it was also found that 77% of global suicide occurred in low and middle income countries, that I just spoke about. That they have found that mostly it is to do with low income group. And that's why a lot of legislature is going to be there for pesticides and for other chemicals which are available, so that especially for farmers, as we see in India also, the suicide rate is pretty high for farmers, and for the low income group. And uh, and this is a very important fact, that we see that for every suicide there are likely to be 20 suicide attempts. So this is where we can actually work towards, because we already know that if a person says, if they talk about it, then there are chances that if there is an uncompleted attempt, then somewhere down the line, if we are not making an intervention, we are not starting some sort of therapy or some sort of intervention, mental health intervention, it may go to the level that they may have completed suicide. Now, coming to this stats in India, this I have taken up from uh, one of the dailies. So in this, our rate is 164, crores of people were reported in India. 7.2%. There is increase ever since 2020. So we do understand that there has been a change from how it was earlier. Earlier, if it was before COVID, the rate was lesser and it has increased. And a very important category that we are seeing that the rate is actually increasing, the suicide rate is increasing, is students. And you might have seen it in the newspapers. Sooner or later, sometimes, somebody not being able to clear some exam, they or somebody not getting the required percentage also, they may actually commit suicide. So, and it, in fact, it has increased by 4.5%, in comparison to 2020. Then, as compared to, what are, as far as the causes is concerned, the maximum is due to family or interpersonal relationships that may go wrong, not understanding each other, and somewhere not feeling that they are getting trapped in some sort of problem, and that may actually lead to this. Then daily wage earners, it was found out that nearly 25.6% suicide rate was there. Then similarly, due to chronic illness, then in housewives it was around 14%. And for self-employed, understanding that this again shows that the financial crunch could be one of the reasons where such attempts are made. So if you go back, I just went back to see what was the rate, and during pandemic was there any increase in suicide rate. And then I found out that in US, in during 1819, the influenza pandemic, it was found that the suicide deaths had increased. Similarly, in 2003 in Hong Kong, due to SARS, in older people, these are all like the data that I could find in various papers. Then there is 1% increased global suicide rate as far as Lancet report goes. And one another study I could find wherein the in the Swiss people had reported that there is doubling of national suicide rate during COVID. So why I'm saying is that, of course, we cannot overlook the elephant in the room, that things have changed. Why is mental health such a big focus now? Because earlier we could we could distract ourselves, go out, but those 2 years, specifically when we were in lockdown, we were completely restricted. Those were the times, there was no running away. And then problems, they financial crunches happened, being in the same space, so relationship issues happened. Students probably face some problems. All the students, I think, had too much of leverage at that point. But now those students who couldn't study at that time, didn't study at that time, might be they are lagging behind, and this is causing a lot of burden on them. So, what are the warning signs that we can see? So, it could be in any way. It could be the way the person is talking. It could be, the way that the person is behaving. You may feel that they are very sad. You may find that the person doesn't come out. They are just, in their home. Or it could be, some sort of loss, financial loss or something. So, why I'm saying here is that once you have, your patients coming to you, and if they mention such a thing and you feel that they are very sad, and somewhere this is something that the physician can actually understand the vibe that the physician is getting, and somewhere you can feel that there is something drastically wrong. So if you can address that, or you can send them to a mental health team, I think that can really work for them. So these are all risk factors which are very important. If any patient, anybody has made an earlier attempt, there are chances they will do it again. Then if they have any pre-existing mental health condition, then again they are at risk all the more. If they have substance abuse, then again they are at risk. And if, very importantly, there is a lot of studies on the genetics of suicide, and it has been found that in families it happens together. If there's a family history of suicide, you will find that it very frequently multiple suicides would be happening. So then and they have found a genetic predisposition as well. Then somebody who has been physically ill for a long time, or they have some sort of condition which is, sometimes there is they find that there is no way out and this is a terminal sort of illness, then again there are chances that they may try to actually take their lives. So then the vulnerable ones, although I have mixed it also, I would say the vulnerable is that somebody who has made an earlier attempt, those are the ones we have to be very careful. That is a red flag. Ever if we find somebody who has made an attempt, then we should be very careful that, there and then they should be started in some sort of plan. In fact, in psychiatry, this is one of the emergencies, and anybody, if we feel is a threat to themselves, they have to be admitted. They have to be admitted till the time we are sure that they are out of that problem. So then people, especially having impulsive temperament, not being able to resolve a conflict, all the more they flare up, and they somehow they think more with the emotional way, rather than being cool and trying to handle a situation. So this is how they think. That is their way of thinking. So they let the emotions get the better of them. So this, they may not be suffering from any illness or anything, but only because they get overwhelmed, and then impulsively they can act. So these are again those clients which we have to be careful about. Then those clients who have, it is always, I would suggest that to all my friends, that if somebody is there and you feel that they are sad and they've been crying, and so ask them, do you think that you have thought of do you think life is not worth it, or have you thought of ending your life at any point? It is not like planting something into their mind. It has been going on in the in they have been thinking about it for a long time. In fact, you may pick that cue. So do not hesitate to ask your client, ask your patient, that do you think you are getting any thoughts, any suicidal thoughts? If they say yes, then go ahead and ask them the next thing. Have you ever tried it? Or before that, ask them, have you thought how you're going to do it? So there they may come out, I will, if it is very gruesomely, and they may say, I want to jump before the train. They may say, I may try to shoot myself with a firearm or whatever. So and in fact, it is seen that men, they do they adopt more gruesome ways of killing themselves, and women try to go for the not so painful ways. It could be by taking pills, it could be by hanging at times, or by drowning. So these things, there is seen that there is a difference. Then seeing that if any point they have spoken about that they want to die, all the threats have to be taken seriously. Nothing can be taken lightly. And if there has been some sort of written letter or something they are writing, that I want to end my life. Some people, they like to write a diary or something, and if there's a mention of this should be taken very seriously. Then all quite often we see that few people, they are they are so upset that they start hurting themselves by cutting themselves, by burning themselves. Now, to understand why do they do that, because they feel so numb that by cutting the, they feel, because of, the uh, adrenaline, pumping, they feel alive again. And that is where, they feel a little relaxed from, cutting themselves or burning, at times. Then LGBTQ community, refugees, prisoners, these are the ones who are at risk. Then anybody who is, isolated. Then, in case if you are seeing a violent patient, I thought, let me just mention about this. What exactly is to be done? Important is you have to maintain a distance. Don't go too close. They will actually, act. In they may be scared and they may act. Then you have to have a very calm and a empathetic look. Then, focus. Try to see what do they have, what are they doing, but show on the face of it, show that everything is calm. If you panic, if you start shouting, you will, it will accelerate the problem at that point. Then keep on talking to them, try to de-escalate whatever, tension has built up. Don't say any of the judgmental things. And then you can try and, you can, either by physically, somebody can hold them, or you can try one of the, chemical ways. And then, plan for treatment. In fact, I have just kept this. I have This is the Nimhans, from Nimhans directory. I have taken this, so anybody who is interested, they can see that what are the, doses, and how exactly one has to do, and what are the do's and don'ts. What are the side effects one has to look for, and what are the parameters which have to be monitored. So these are some of the things. Some of these antipsychotics at sometimes, benzodiazepines at sometimes, phenothiazine at sometimes. So these are some of the drugs which can be used. So while talking to them, what is important, that it is important that you say that, you are there to help them. I'm here to help you. Listen to them. Don't say things, you have nothing to worry, everything will be fine. Don't give such dismissive comments. You have to, listen to them. You have to validate their emotions and whatever they are saying. And then, you shouldn't be judgmental, saying that you should have done that, why didn't you do it, something like that. Those judgmental things should not be done. And, some way you should say, but you tried, but you never knew about it. You thought this will be fine. This is how it should be done. And then keep on showing empathy, then saying that I can understand you and your situation, and that almost everyone is feeling the worry and anxiety, some that sort of a thing. Be very supportive, instill hope. And by the end of it, if you feel that client is actually, is convinced, and you have been able to establish a good rapport, ask them to, promise you to not harm themselves. In fact, in our clinic, we actually ask the client to write a no suicide pact, wherein they sit and this, and it's very important that you have to inform their family members there and then. Sometimes when they come and they talk like this, and they say, don't tell it to my parents, don't tell it to my, and then we, right in the beginning, this is the one clause that we tell them, that, this confidentiality stays, this doctor patient confidentiality stays only till the time that you are not any harm to others or to yourself. So at that time, you can always tell them that, see, I had already told you, if you are harm to yourself, I can breach this trust. Now, your parents somehow try to, convince them, try to make them understand that, we have to tell your parents. It is important. Your family has to know about it, so that, the right action. And, quite often then when I sit with my clients, I tell them that, this is not what you want. This is certainly not your thoughts. Please label these thoughts. Tell them that this is, my illness talking. This is not what I want. Once I am better, I would never like to do this. So this is just about a few chemicals which are actually going down, which are making you, act in this particular manner, and that is the reason why you're failing. Then any of, self-harm patient, if you have, talk to them, distract them, talk about something or the other, try to de-escalate, the tension if it is there. If something particularly happened, talk about it. Encourage them to talk about. then show them that you understand what they are saying, and you are there, you are there to help them out. Always inform the family, and make them to sign a no suicide pact, which we always do. And then and then we are very very conscious that they have they seek help regularly. But if the threat is really severe, then we always ask them to get admitted in a psychiatric facility. Then these are few of the assessment tools that which are there. There's a Beck scale, suicidal ideation, then suicide intent scale, and few of them which as you can always fill them, and accordingly it can be worked upon. Then it's quite often that patients who are already suffering from some mental health condition may have this sort of impulsivity, or at some point feeling that they want to end their lives. So few of them which we can talk about is, of course, major depressive disorder. Then these are the illnesses. So how I explain people is that illness is the embellishment that you have on a picture. Okay, so what is the picture exactly? Picture is the personality or the thought that you have. So illnesses are something on top of it, but you have to understand what is the thought process, what is the personality. That is the very core of the thread of the entire of that person. So anybody who is having borderline personality disorder, they are the ones, quite often they may say, because they have that extreme splitting. Either things are very good or they are very bad. Nothing is in between. And sometimes, because they feel so empty from inside, that this is how they try to counteract their emotional distress. Then substance, if somebody is having some type of substance abuse, any eating disorder. So these are the things, schizophrenia, and these are the illnesses that we can talk about in if anything you want in particular, we can talk about it. So these are few of the illnesses which make you susceptible to such sort of risk. Then while we were talking about this, there one particular category which is very much overlooked and taken for granted by us is we ourselves. So it is very important to take care of yourself. So it is important to take care of your mental health as well. So it is very important that you have professional boundaries. You understand that work finishes once you are coming out of your hospital. Of course, I understand there are certain specialities, but then being in a group or something, practice that can help, but you need to maintain professional boundaries. You should not, as mental health professionals, we strongly recommend that you need to have that peace of mind when you are at home. Because end of the day, you may have all these degrees, but the body and the mechanism, the physiology is just the same. So we are just knowing things is not going to protect us. So we have to make that effort to protect ourselves. So we need to manage stress by deep breathing. In fact, one of the studies in UK was done which showed that deep breathing can actually be as effective for mild and moderate depression and for anxiety as much as any any of the SSRIs or antidepressant. So, and regularly talk to a therapist. It is very comfortable. It is important, or to one of your peers, one of your colleagues. So keep on talking. Do not bottle up. It's important that mental health is equally is very very important. Regular exercise and maintaining sleep hygiene, all these are important. Then prevent burnout, take regular vacations, maintain a healthy social life, start a new hobby, practice mindfulness, and of course peer supervision, wherein all the pressure doesn't come on you. You have a group wherein you can go and talk about your complicated cases or whatever, so that the pressure doesn't completely come on you. So that you are it's always better to have some sort of support structure around you, even in the professional field. Then coming to, it's important to have some sort of supportive communities, for suicide prevention if it is there, and for the to reduce the risk of suicide. And it can be very, few of these, especially for senior citizens. There are certain senior citizen, associations are there, RWAs are there, religious sort of, meetings are there. So all these things, they help to keep you connected, and that plays a very, very important role. Then whenever a crisis is there, one should beforehand make some sort of the way of handling that situation. When it comes, then thinking of how to handle is not the right way. So beforehand, one should be ready with, in case something happens, if, for that matter, if violence also happens, we should know exactly how to handle that situation. And a lot of training can be done for that. So, and taking professional help as and when need be is also very, very important. So these are some of the references that I have taken. It is either from NIMHANS, or most of them are from WHO. So this is what I thought of. Let me talk about. So thank you so much, and I will ask Vidya to take over.
Thank you, Dr. Anjali. It was a very, very insightful presentation. And to all the doctors present, in case you all have any questions, you can type it in the chat box. Dr. Anjali can address them. Um, Dr. Anjali, just to kickstart, I you mentioned that patient confidentiality is important, right? But do you always need to discuss it with the patients before informing their parents or caregivers?
Always, always,
Okay.
every time. Each patient is equally important, and all the rules have to be followed every time. As far as mental health is concerned. you know
Okay.
for psychiatry, it's very, very important, because it is all, this entire specialty is based on trust.
Correct.
It is completely based on trust, in the sense that the client is coming and opening about their deepest, darkest problems. So if, in case, if you're breaching that trust, they will stop believing you. They will stop believing you. So it's very important that every time we have to actually take permission from the client. In case, even if they don't, agree, we have to inform them, like, okay, this is how it is, and I feel this is something which has to be, immediately taken care of. So that's why we are informing you,
Yeah.
or whosoever is nearby.
Okay. So Dr. Sarish has asked a question. I want to ask regarding a person I know. They are just not talking to anyone. He is harming themselves and having suicidal thoughts. How can we convince a person to seek treatment?
Start a dialogue. Start talking to them. Keep on talking to them. Tell them, and if the threat is like, if you think it is going to be carried out too soon, then I would say, then you need to call one of the mental health clinic, and then they, if two psychiatrists sign on that, then you can even take them without their consent. But then they can be kept only for, I think, 9 days or something, and then again it is heard of. So yeah, so keep it. I think they, most of the patients that I have seen, they want to be rescued, they want to be helped, but they are so deep down into their miseries, and the chemical cascade playing havoc, that they are clueless. So you just need to give them that hand, they take it. You don't say that you are troubling others. Tell them for their good. Tell them of like, for for women, you can tell about their kids, because whatever their soft corner is, use it. If they are very much attached to somebody, use it. Even he is talking about this thing. Do you think that is how sometimes it works? And you keep on trying, and if it will, most of the times I've seen it works, unless and until there's some major sort of psychiatric diagnosis, and some category wherein, then of course you may require involuntary sort of admission.
Mm. Okay. Dr. Sarish, I hope Dr. Anjali has answered your question. Yeah, thank you. Okay, Dr. Anjali, how can we differentiate between passive suicidal thoughts and active suicidal ideation?
See, as far as suicidal, thoughts are concerned, if you are making any sort of plan, and if you are actually thinking, then there's something before that wherein you are losing interest in your life, and that is, uh, uh, just death wish, that it is, nihilism thinking. If something, finishes, it will be good. Yeah. But in case if you are actively thinking that, okay, let Diwali go, then this will happen, then I will make a plan, then I will take this, then you are trying to put things in order, finance should be taken care of, this, that shows that you are actually thinking of contemplating it, of actually, doing it. So that is where, the change would be there. So somewhere, if you are actually making a plan, or you have made, some sort of an attempt, then it could be that you may be getting into that category wherein immediately some help is required.
Okay. Okay.
So
Okay. Dr. Anjali, also, are there any legal considerations surrounding the assessment and management of suicidal risk?
see, legally, I would say that it has been decriminalized now that we know. I think in 2013 or something, or I don't remember exactly which it was. So legal implication is not there now. Whatever happens, it is the physical and the psychological part which has to be, taken care of. So as far as I know, there isn't much, I can think of that legally. If now, after, all these changes that have happened, and that is what I said, Vidya. That is where all the work is being done. In this year, I was seeing in WHO throughout the world, they are actually working towards decriminalizing it. So though, this thing should not be there. But again, knowing that somebody is going towards this, thinking about it, acting in time, taking the right steps, that is very much required, and especially for the ones who are, around these people. It could be the relatives, it could be your friend, probably it could be your colleagues, anybody, around you. So if somebody is not, wanting to communicate, it is not fine to actually leave them as it is.
Mm.
It is important to ask them what is wrong, where it's wrong. And I think therapy is one thing which really helps. And it is, there's a lot of stigma attached with mental health. And a lot of myths are there that these medication are addictive. You are not, even I have seen so many, times, few of the medical fraternity saying that, it's impossible to come out of it. But this is exactly what I tell my clients, that, if somebody is having diabetes, you do not tell them that it is addictive. They might take it for life, but then, that is how the chemical setup is. That is where that particular area in your brain, say if it is anxiety, locus coeruleus is the area which is producing too much of, these compounds. So then we have to work towards it, we have to reduce it. And similarly, if dopamine is being produced too much, then we have to reduce that. And for reducing that and all that, it is important that, some medication has to be taken. And if together with that, sometimes it is not just about, the illness, it is also about the thought process. And no thought can be changed by medication, so that
Mhm.
has to be done by psychotherapy. You need a proper psychologist for that. And it is not about, incomplete sort of a treatment. One or two times you go and you feel that you have ticked the box. No, it is a long process. Sometimes it is the, the sort of environment that we are in. It is the way that, the cultural sort of biases are there. So fighting with them, and talking and understanding, what is in tandem with finding out solutions, and where are you going, where are Where is it that you are having those maladaptive sort of, thought processes? And what are the reasons? Why are you not able to cover them? That
Hmm.
is in one process which needs to be done. Why aren't you? Are there defenses, which are coming up every time there is anxiety? You don't want to, you get into, intellectual thing that you're talking about, this thing happened, this percentage, that percentage, not trying to understand where is the problem. So these things, we have to, that is where the psychology, the psychologists play a very important role. That is more towards, the therapy part. But of course, for doctors, for psychiatrists, we are like, for us, Vidya, I am doing a lot of work on quantitative EEG. We
Hmm.
have a lot of work, reading where, the brain areas. So just the way that I feel that EEG was, ECG was being done earlier. Similarly, we are doing a lot of work to understand how the brain is functioning, where, which waves are not, not going the way they are supposed to be. So how we do it, we take the we record the data of EEG for about 1 hour, then we upload it on a system. There are about 4 to 5 normative data all over the world. I think two of them are in US, one is in Germany, one is in UK, one is in Russia. So then, you one of them is QEG Pro, which we are in touch with. So there they have, the uh, uh, they have reading of, about, say, thousands of, patients, as according to their age. And then accordingly we come to know that, okay, fine, this particular area is not, working the way it is supposed to work.
Hmm.
Might be, so many times, while I'm doing it, we understand that, okay, this client had ADHD right from childhood, because the frontal lobes are actually, very slow. Or
Hmm.
sometimes we find out, oh my god, this patient has autism spectrum, disorder. Might be very early, it is a spectrum again, so but they have that, and that is the reason why they are being, a little rigid, or they are being a little sticky. They do not gel in the society, they do not make, they are labeled as weird, or a little, not easily you can gel with them. So that's where we pick up, okay, fine, this is what it is. It is not something to do with, any of the personality disorder. It is nothing to do with, any of the, clinical diagnosis. It is something to do with, neurodivergence. So this is how they are. They're different. And this is how they have to be accepted. So,
Yeah.
yeah, that is where we work on that.
Okay. Doctor, we've got two more questions. Dr. Akarshan has asked what systemic changes or improvements in mental health care infrastructure and policies can help reduce the prevalence of suicide risk factors and enhance early intervention efforts within clinical practice.
See, as far as the policy level, I think already a lot of work is being done. It is not about the policy now. It is about how much it is implemented, and
Mm.
how much are we we are working towards it. So there are policies very much in place, and to pick up these all these at risk population, to find out where it is going wrong. And somewhere, I think, rather than waiting for the time that actually this is happening right from the childhood, when the child is actually not able to have academic difficulties, they are having, not able to gel up, that is the time these clients should be picked up.
Mm.
So that is where I think a lot of work is being done. And that's what I was seeing in Imhans. They are working a lot towards it. So I would say that at various levels these have to be done. Like, if like having these school counselors, this is a very good thing. Now they are making it mandatory to have a school counselors, to have special educators. So lot of screening can happen there and then. Lot of problems can be screened. If they are not screened there, if they keep on going ahead, and then later, when it may come out as a major depressive disorder, but might be the reason was much different. Might be it was their academic disability that they had. Might be it was the way that they were not able to, interact with their peers, and probably they were labeled to be, weird or boring or something like that. So so that's where I think, and I think there are a lot of interventions which are already happening. The policies are being made, and I think we will be seeing a lot of changes happening soon.
Okay. Okay. Thank you, Doctor. So we have one more question. Dr. Kansara has asked us, hello, ma'am. Some patients only think of suicidal thoughts whenever they are having a bad day. There are plans that are not working or may have argued with their families. They don't act on these thoughts, but these thoughts keep repeating daily. But there are some patients who don't speak but directly take actions for suicide. So how do you manage the two cases?
Exactly. Both of them can be there. See, as far as those patients who are thinking again and again about suicidal thoughts, I would say these are the clients who may be dysthymic, who may be having, that sort of personality that they may be overcritical, and their coping skills are not that strong. Rather than, see, what I feel is that with every difficulty, you become stronger. So understanding that how whenever a difficulty is coming, not giving up, that is where, the therapy with the psychologist should happen, and working on their coping skills, why they are not able to take the problem as a challenge. That is one thing. And secondly, these people that I would say, these are the ones I just now mentioned, that many of them could be borderline personality. So they may have extreme sort of, or they could be having some impulse control problem. So this could be one of the categories, diagnosis that could be there. And that's why all of us, this could be static of bipolarity also. A bipolar disorder can also, because the frontal lobes, the seat of willpower is not working, and, they may have emotions, but the brake isn't there in the frontal, and they just act on it. So it could be any of these. They both, depending on, what is the mental, makeup of that person, accordingly, the treatment plan would be devised for them. So whatever, may seem while talking to them, more or less, we are able to gauge whether it is just about this, this problem which is, out of proportion, which has come, or there is some maladaptive, way of handling that problem that is patient is suffering from. They do not understand that how to handle a situation. So then we have to keep on working with them to first to make them aware that where they are running short. Then some analysis, why are they running short, what happened, why are they not able to handle this situation, and then slowly working towards it, and enabling them, making them see. Again, the therapy doesn't mean that you are dependent on the psychologist. The role of the psychologist is to enable you, to make you strong enough to pick up whatever signs are there, or whatever factors are there which can push you into such a situation. So beforehand, if you are prepared, you understand that, okay, fine, if there is a problem, if I'm pushed to to the wall, I may react in this way. And then it is not at that time that you will devise some sort of plan. You should already be trained that, okay, fine, this happens, this is how I react, and this is what I am supposed to do. So all that work needs to be done with the psychologist. That's why it is not at that point that the treatment is important. It is important that you should be growing, slowly understanding yourself, each and every part of yourself, the way that you're thinking, why you are thinking that way, what happened, why do you react. Same situations, you put 5 people, each one will react differently. So why is it that some may come out much stronger? So why is it that actually you disintegrate in such a way? So going in that sort of work is very, very important. Understanding why is it? Why can't I face? Why can't I come out stronger? So that work, you need to just sit with a psychologist, understand. Okay, fine. This is where my shortcoming is. This is how it happens. This is might be genetically I'm predisposed. Few people are predisposed to have anxiety disorders. Few may be predisposed to actually feel very high, grandiose, and all. but then the very knowledge that you have can actually, protect you from actually being in that danger.
Mm. Yeah.
So, yeah.
Okay. We have one more question from Dr. Sakshi. Patients who have undergone sexual abuse also have suicidal thoughts. How can we help them as these memories trigger them?
Very true. So I did mention about the violence, and yes, in that violence, of course, that sexual abuse was a very important part. Thank you so much that you have pointed out. And yes, the sexual abuse, in fact, when we were doing brain map, we were finding that, the visual part, sometimes, very complicated cases, we are trying everything, and we are not able to understand, but the visual cortex would show that, the waves are very fast there. And then we will try, and we then found out that it is, the earlier memories which keep on coming back, those are the ones which may cause this sort of, symptoms, or whatever thing. So in PTSD, we have found that a particular part of the brain actually starts firing too high. And for these people, only thing is that when too much of stress is there, or if you are not strong enough, not strong is not the right word, if you are not, uh, you are not trained well enough to handle situations, so these problems can keep on, accumulating. And it is just like you compress a file. Similarly, your unconscious subconscious brain starts getting filled up, and then from there the symptoms start, the flashbacks, the numbness, and all these things start. So what would be the best way? Therapy. Talk, decompress, decompensate, talk about it, so that slowly, when does the brain actually process? It is important to process whatever is going on. If you don't process, it is going to accumulate. So what you need to do is, you need to talk, you need to, somehow keep on, bringing it out. And sometimes in your in your sleep, you may get dreams. That is the time that the filter is going down. So all your subconscious, unconscious things are being thrown out, just like a sea. It throws all the dust out. So at in sleep, it comes out. Or if similarly, if you can do in the daytime, put all your filters off, just talk to the psychologist, the therapist.
Hmm.
Slowly, it will take time, because it is so compressed that it has reached a stage where it is, giving so many symptoms. Okay, as they say, कि पानी भी पड़ा हुआ बदबू दे जाता है. And see how much long these things have been accumulated in your brain. Now they are giving symptoms. So you have to keep on, regularly be in therapy, understand, then only the resolution starts happening. So I would say yes, these memories will be there. Do not try to numb yourself. Do not try to run away from it. You have to process your thoughts. It has to be processed. There is no other way. Medicines, you want, I don't, if it is too painful, we can actually, delay it, this process. But sooner or later, if you need complete resolution, you have to bring it up.
Hmm. Hmm. Okay. Dr. Sakshi, I hope your question was answered. Yeah. Do we have any questions? Any other questions?
Not too many questions today.
That's. I think you've given all the information everyone needs. So maybe
Hopefully,
that's enough.
hopefully, yeah.
Yeah. Thank you, Dr. Anjali, for joining us today.
Thank you so much.
Thank you to all the other doctors also. We promise to. Okay. Cool. Okay. Thank you to all the other doctors also for joining us today.
So
Hope you all have a nice Sunday.
we are giving back 5 minutes to everybody so they can make full use of that time.
Yes, yes, yes. Okay. Thank you, ma'am. Thank you so much.
Bye. Take care.
Bye.